So after the presentation, hopefully you'll be able to describe the role of long-term care nurses in an ASP program, or an ASP. Describe the challenges of implementing one in long-term care, boots on the ground, you know, the information that we all get, but the actual implementing it sometimes isn't quite so clear and easy to do. And then to outline the process of the consultant pharmacist antimicrobial assessment in long-term care. So there's three main roles of the nurse. So communication is the first, and it seems like no matter what you're talking about, if something is going to fall through, it's some level of communication. If you look at everything we do as nurses, sometimes the problem starts within the level of communication. So some barriers to communication, it has the definition there. I'm not gonna read it to you guys can read. Is the education. So there's so many new things, so much new information out there, making sure the education gets out to the people that really need it. The culture of antibiotic use. So many things that we do in long-term care we've been doing for a number of years, and it's ingrained into who we are, and it's like our muscle memory. And so reprogramming our thought process in how we use antibiotics. Also in long-term care, especially in nursing, we tend to have limited resources. So we're asked to do more with what we already have, and sometimes is already stretched. So as we do as nurses, sometimes we have to get creative. And then residents and visitors, families. Oftentimes we can try to educate, and sometimes it's the family members because of information they have received or maybe other facilities they've gone to that are very assertive on what they want. And so that can also be a barrier, and looking at ways that we can work with each other, how other people have handled it can be helpful. Some opportunities, so we have these barriers, so what can we do to kind of reduce the barriers, or if we're really lucky, eliminate them? Training, we can never train enough. Again, sometimes that's also a barrier, because if you're already dealing with limited resources, trying to get that training out in an effective way, in a timely manner, sometimes can be a little difficult, so thinking outside the box. Taking the resources that we have and using them more efficiently. So working together as teams, working together multidisciplinary within our facility, and being able to kind of delegate out other areas to other departments. Using, as far as resources, the efficient use of resources would be, like we've taught, a number of presenters have talked about today, the use of SBARs. So the use of the SBARs will give concise information, it'll give what you need in a quick manner, and it'll increase the communication with the provider. It'll also increase the communication between one shift to the next. Educating our families and our visitors and our residents about why we are making this decision, why not everything is treated with an antibiotic anymore. Measurement, so as nurses, you know, we take vitals, we assess the individual, which comes next, but some barriers to that might be documentation. So oftentimes, I always say we do so much and we take credit for so little. There's a lot of things that our nursing staff and nursing assistants that are doing on a daily basis, but it's not always getting clearly charted. So then it's not getting communicated, and then when chart reviews are done, it appears that these different steps aren't being taken. So that's a barrier, incomplete documentation. Also as we're looking at SBARs and information like that, we're looking at closer observation longer. Many times in our long-term care facilities, we know our residents, we know who they are, and sometimes maybe that could also lead to the opposite of you're used to somebody. So sometimes a fresh pair of eyes can help that. Opportunities would be the use of the SBAR. I know that we've said that a lot today, but I think that that really is going to be, it's an invaluable tool that is going to help on multiple levels. Oops, wrong way. So assessment, so we take the measurements, we take the vitals, and then we put our whole story together and we decide what how this information is going to improve the quality of care for our residents that we take care of. So how we're looking at, as far as looking at these different things, Dr. Ashraf talked about the SBARs, the UTI SBAR, looking at, so once they don't meet criteria, the individual might not meet criteria for a UA to be done, so, but we want to monitor them. It doesn't mean that, okay, they don't qualify, so they must not have a UTI. That's not necessarily what it's saying. It's saying that now we want to monitor them closer, and so that we will catch something sooner. And all that would be listed in the SBAR, the UTI SBAR. Also, another barrier is time, like we said. So many things, especially with all the new regulations that came down for long-term care, is expected to do a lot more with still the same amount of resources that you had before those expectations came down. So again, it is going to take a think out of the box, seeking out your resources. Other people you have in this room as phenomenal resources, your peers, kind of this all in it together type mentality. By doing all this, we're building on the quality of care. So the SBAR is a standardized form between the nurse and the provider. So it will answer a lot of questions that the provider will have, and will be right at their fingertips. And again, anything we're doing is also improving the quality of care for our residents that they take care of every day. So a paper was put out by the, oops, went a little crazy there, sorry about that. Touched the little pad there. The ANA and CDC, this is a paper they put together. Not gonna read it all to you, don't worry. So this first slide talks about the nurse's role at the time of admission. So we want to use appropriate triage and isolation. So that's the communication between the nurse and the IP, the infection preventionist, the infection control person, whatever the position is called in your facility. That is the key component. If the infection preventionist doesn't know about it as soon as possible, then there can't be that collaboration. Communication with other people within the facility, and communication with whom you're getting the information from. So when they're discharged from the other facility and they're coming to you, getting that information as clear and concise, and working with your other facilities. And then also communication from your admission staff. So the individuals that are bringing in the residents to your facility, or when they're being readmitted to your facility, making sure you have that communication in place, whether it's stand-up meetings or that you're getting involved in, making sure that the appropriate people know. Make sure the accurate antibiotic and allergy history. So understanding that if somebody is allergic, knowing whether they're allergic to the antibiotic. We talked about one of the problems with overuse of antibiotics is the adverse reactions. So make sure that that's clearly defined on the chart. If they received antibiotics in the hospital at other facilities and they had a reaction, make sure that that is communicated. Complete the information for antibiotics, complete information about the antibiotics. Sorry, just checking my time. And if they're on antibiotics. So make sure you have the dose, make sure you have how often it's supposed to be given, how long it's supposed to go. So the duration of therapy is really important. So when an infection is suspected, so you kind of think you have an infection, but you're not sure, the comprehensive evaluation, so a detailed assessment where we're looking for clues, we're looking for what is causing this. A lot of our residents that we have aren't always real verbal, and so again, you have to be very perceptive and making sure that gets documented so that when you're looking at the history and you're talking to the physician or the provider, that you can give them the appropriate assessment. Communication with the prescriber and the provider, that's the SBAR. When you think you might have an infection, making sure that's completely filled out. Every aspect of that SBAR is filled out before you contact the provider. The initiate management plan, the active monitoring documentation. Look at the antibiotic order, revise, the dose may need to be revised, the timing, connecting with your pharmacist, making sure that communication is open so that, they're gonna have the updated recommendations before we will as nursing sometimes. Early appropriate cultures. So again, not only getting the cultures before you start antibiotics, but make sure when you're getting the culture that your technique that's being done is appropriate. So if what you're doing is contaminating the culture, you might as well not do the culture. So working with staff and doing staff education on that too, if your results are coming back with a contamination. During management or suspected or confirmed infection, progress reporting, so keeping in touch, see is it getting better, is it staying the same, is it getting worse? Antibiotic adjustments, de-escalation was talked about just prior to our presentation based on the lab reports. So if you do a culture, if you're treating before you know what you're dealing with, you do a culture, if it comes back resistant to that, making sure that that's communicated quickly so that the appropriate therapy can be initiated. Antibiotic dosing changes based on the drug levels and other lab reports. Again, keeping in contact with your lab and your pharmacy is important. Monitoring for adverse drug events. Again, we're trying to use the antibiotics only when necessary, but when we do have to use them, just making sure that it's appropriate. And then antibiotic timeouts, so 48 to 72 hours after antibiotics are started, reevaluating, again, is it working? Is it consistent with the information that we now have? Are the cultures telling us that, yes, this is the appropriate therapy? Okay, at other times, so our role at other times in nursing, question the medical necessity for diagnostic testing. So oftentimes, making sure it may not be your provider within your building, it may be a specialist that is being seen, your residents are being seen by a specialist, and there's been a change in behavior or maybe foul-smelling urine, and they automatically want to order a UA. So looking at that and reassessing, do you have other symptoms that would lead you to believe that? So you know the resident, you know their history, and assessing whether, and having a discussion with the provider or the provider with your facility on that. Coordinate with the IP and the pharmacist on ASP activities. So it's important for nursing to get involved with the Antibiotic Stewardship Program because the nurses are the boots on the ground people. Those are the individuals talking with the families, talking with the physicians, so getting them involved. And then again, educating families and residents on appropriate antibiotic use because sometimes that is the issue. It's, maybe they go to the hospital and they get put on something and then they come back to us and we're saying, really we don't have the documentation, let's try this. And they may not want to not be on antibiotics. So the communication with the family and why is in the best interest of the resident. So just some questions about when we look at what the role of the long-term care nurse participate, or what activities can a nurse participate in to decrease the unnecessary antibiotic use. So the options are help develop an SBAR, use the SBAR, clear communication with the physicians, assess all other causes of symptoms or all of the above. You can just say it out loud. All of the above. So they need to be involved in all of those. And then the potential barriers to implementing a program of ASP nursing activities. We had talked about, it'd be A and B, the culture and the resources. So just changing our way of thinking a little bit to what it's been, to what we're kind of heading towards, and then also, again, the limited resources that are that aren't available to many facilities. So I will pass it on to Rebecca now.
Thank you, Tammy. It was really appropriate in my mind that they asked the nurse and pharmacist to speak together because we really are doing a lot of collaborating on this ASP. As several people have mentioned, it's not just a one person's job, a one-man show, it's a team effort. So I'm going to speak a little bit about the consultant pharmacist role in stewardship in my experience. So as was mentioned earlier, the CDC core elements recommend that the consultant pharmacist is a part of the stewardship team. Like Dr. Ashraf mentioned, we do bring that drug expertise. We'll talk about that a little bit more in the presentation. The pharmacist has access to pharmacy data a lot of the time, and we are already reviewing each resident's chart every month. So why not pay special attention to those antibiotics? So assessing appropriateness can be a challenge. We've talked a lot about obtaining duration and dose and indication, but how do we determine if it was appropriate? So consultant pharmacists are accustomed to assessing appropriateness. We do that on a daily basis, whether it's with psychotropics or antihypertensives. That's kind of what we're used to doing. If your pharmacist does not have a baseline knowledge, as Dr. Ashraf mentioned, there's lots of resources. ASCP has training available. We also are already reviewing charts and sending letters to prescribers. So at the time of our monthly review, we can send letters to prescribers if things are inappropriate. Now that could be current therapy and it could be a retrospective review. Either way, we are viewing it as it's still an opportunity to educate. If any of you have ever heard providers complain about the amount of letters they receive from a consultant, you will know that that will motivate them to make better choices. So by doing that, we're giving physicians a recommendation for future prescribing. Easier when they are in-house provider. As it's been mentioned, it's definitely more challenging when they are not someone that is affiliated with us. It's hard to affect those ER docs, urgent care, that kind of thing. So your consultant pharmacist may have access to pharmacy dispensing data, which can provide the facility with some assistance in obtaining all of the data. Things that we are monitoring for are total number of residents on antibiotics during a given month, new antibiotic starts, and total days of therapy. While we are performing the chart review, we can review the % of new antibiotic orders where the SBAR was used, if that's something you've implemented. We can kind of be that double check for you to see if staff is following through. And then as far as appropriateness, we are using McGear criteria or Loeb criteria to assess inappropriate versus appropriate. Now, a barrier that we've been seeing is, like Tammi had mentioned, documentation. So we are going to deem it as inappropriate if we don't see these symptoms documented, but sometimes that's not the case. It just wasn't documented properly. So again, stress the importance of that to staff. Other things we are looking for is total number of adverse events reported with antimicrobial therapy. And lastly, which prescribers are consistently prescribing inappropriately. Again, something that was mentioned earlier is giving providers feedback. I think that is really important. As we're looking at trends in our data, we're going to be implementing some kind of a reward system type thing, or recognition for being a good prescriber. Drive that competition, kind of. Okay, so to get a program up and running, what I have done with my team is we were fortunate enough to work with the UNMC infectious disease experts. So we were trained in ASP implementation programs to help our facilities. So we have been out there kind of doing our thing in long-term care facilities, helping them get started with antimicrobial stewardship programs, providing them tools and templates and guidance obtained from our sessions. And like Dr. Ashraf mentioned, a lot of that is available to you on the ASAP website, so no worries if you're just getting started. And as Tammi mentioned, there are so many barriers sometimes for the IP. Not that we have all the time in the world, but with the two of us together, we can kind of conquer that effectively. And again, it shouldn't have to be just the IP driving the program. We need the involvement of everybody. That slide, the cartoon that Dr. Cernich had before of the men in the boat, if your pharmacist is that person sitting in back, you should come talk to me. That's not okay. Okay, so our process that our consulting group has taken is we're reviewing every antibiotic order for appropriateness on a monthly basis. Like I said before, that could be current, it could be retrospective. And then we are providing written feedback to prescribers for inappropriate prescriptions. We are reviewing use of the SBAR tool, if it was filled out correctly, if it was or was not filled out, and reporting that back to Director of Nursing. And then kind of having a chit chat with the infection preventionist every month to identify barriers or what still needs to be done, kind of just helping keep them on track and working together. So this was kind of mentioned earlier too. Tracking is a big part of stewardship. Lots of different things we can track, which is very helpful if we have the pharmacy data. So number of antibiotic starts per 1,000 resident days. Again, your pharmacist will need some of your help obtaining that information. Whatever your billing department is using for resident days, we would need that information. Days of therapy of antibiotics. Number of antibiotics reviewed in each month or each quarter, whichever way. We are just now kind of at the 6-month mark from when the regulation began, so we're all still kind of learning this together. We've been tracking the the data for 6 months and actually putting it in an app to be able to get our results. And our facilities have been waiting patiently for some of those results, and I am really excited to be able to present it to them. I think it will be very eye-opening. Once we are able to look at all that app data, we will be able to assess what the most common reasons for inappropriate prescribing were, and just the proportion of appropriate versus inappropriate. And like was mentioned earlier, in addition to that, you could also be looking at duration of therapy. That might be another target that we can try to affect, which we are sending letters to prescribers for that as well. So also, as mentioned earlier, your consultant pharmacist can attend your quarterly QAPI meeting and maybe have a stewardship meeting on top of that or in addition while the medical director is on site. That's worked pretty well for some of our facilities. Working with the infection preventionists to develop reports, kind of being their support system. Assisting the ASP committee in providing templates and reports for prescribers. And regional benchmarking data is something we can also provide. Currently, we are working with Dr. Ashraf's group and have 32 facilities enrolled, and a lot of people do like to see where they compare to their peers. We're able to break that down by facility size and skilled versus non-skilled population. So that's been really interesting to see that form. Here is one of those, just a baseline of what we started with. I think someone mentioned earlier how you're not going to know if you've improved unless you have your baseline established, and that has been a challenge because prior to November of 2017, when the regs started, a lot of people weren't tracking these things, so we don't know where we started before November. But you know, it's a process, and we're doing it and we're working on it, so we are confident we will be able to show improvement. Education is another thing your consultant pharmacist can provide. As I mentioned before, we had some training from Dr. Ashraf's group, and for those who haven't done training yet, there's training available through American Society of Consultant Pharmacists, and even just a lot of the resources that Dr. Ashraf has mentioned for facility staff. So we can help facilities with resources for educating staff and families, inform facilities about opportunities like this summit, and then one-on-one or group education. You know, sometimes I feel like the IP or the DON, they think their staff needs to hear it from an outside source, what they are doing incorrectly or should be doing better, so we are happy to step in and give our insight. It's always better for us to point out areas that are lacking before the survey team comes in, so utilize your pharmacist. Okay, so there we are to the end already. An effective antimicrobial stewardship program should include the collaboration of the team, like has been stressed several times today. Communication between nursing and the prescriber is essential in improving appropriate antimicrobial prescribing. Like Tammi mentioned, we are really pushing the use of the SBAR tool because it's been studied and proven to have good outcomes. As Salman mentioned, providers would rather receive all the information so they can make good choices. Nursing is their eyes and ears. They are reporting to the physician in a lot of cases where the physician is not in the facility to see the resident, so they need the most accurate information. Consultant pharmacists can help facilities identify inappropriate antibiotic use and to help track trends. Like I mentioned, if your pharmacist is the one sitting in back, should not be doing that at this point in time. And long-term care facilities should involve all their nursing staff. We need to incorporate everything we're learning to the people on the floor, because if we're keeping it to ourselves, then we're really not going to see a greater improvement. We are not always there to monitor these things, so we have to really empower our team and get everybody on board. That is it. Thank you so much for attending, and we'll take any questions.